Hi, my name is Neil Gajewski, and I'm presenting on radial tunnel syndrome today. So my first slide is just a quick anatomy overview of the radial nerve. It arises from the posterior cord of the brachial plexus, and it separates into the deep and superficial branch. Below is what the nerve innervates, the muscles, and it passes through the radial tunnel and the arcata fros, which is a fibrous arch formed by the two heads of the supinator, and this is the most common site for compression of the radial nerve. So for clinical presentation, the client will experience a dull aching pain located in the dorsal radial proximal area of the forearm. Pain increases with movements that increase traction to the radial nerve, such as forearm rotation, elbow extension, forearm pronation, and wrist flexion. Pain typically increases at night, and there are no motor or sensory components typically associated with the syndrome. Fatigue and muscle weakness that the client experiences are due to the pain. The most common diagnosis that presents with a lot of the same symptoms is lateral epicondylitis. So for radial tunnel syndrome, the client would experience pain, tenderness 4 to 5 centimeters distal to the lateral epicondyle, and for lateral epicondylitis, the patient would experience pain right on the lateral epicondyle. For evaluation, the clinical symptoms are not just specific to the syndrome, so it's really important to gain a really in-depth occupational profile, knowing the occupations that your client is participating in daily, what movements are associated with their work, where they're experiencing pain. The DASH can also be utilized to gain more of an in-depth on their symptoms, as well as the daily occupations that they are struggling with the most. So some occupational risks are lifting heavy objects for long periods of time, excessive pinching and squeezing of objects, and excessive extension of elbow or forearm pronation or supination. So knowing the occupations that your client is participating in can help you knowing what movements they're participating in and if they're engaging in any of these occupational risks. Some provocative tests are resisted middle finger extension, resisted supination test, passive pronation with wrist flexion. These are all tested positive if it reproduces pain at the radial tunnel. The radial tunnel injection test is positive if the injection leads to posterior interosseous nerve palsy and relieves radial tunnel pain. An MRI, ultrasound, and electromyography are often used to rule out other diagnoses with similar symptoms. So for non-operative treatment, the client would be immobilized at the level of the wrist, splinting in forearm supination and wrist in about 15 degrees extension. It's primarily worn at night, and it's worn 4 to 6 weeks with a gradual decrease depending on how the client presents. If the client is still experiencing a lot of pain, they can be splinted at the level of the elbow. So the elbow is placed in 90 degrees, forearm in supination, and wrist in neutral. And this splint is worn at all times except for hygiene and range of motion purposes. The client can take anti-inflammatory meds. They can use modalities in OT, although there's not a lot of evidence surrounding that, as long as it's not inflicting pain or as long as it's not harmful and it's helping with pain, the client can utilize those. For occupational therapy, the OT would work on activity modification, nerve gliding exercises, stretching and strengthening, and core strengthening, because this syndrome can often be associated with poor posture. There's also evidence that corticosteroid injection alongside occupational therapy can be beneficial. So the client would go to OT 1 to 2 times per week for about 6 weeks, which is client dependent upon how their pain is progressing. So these are the radial nerve glides, which restores nerve motion. So the client would drop their arm loose at their side, drop their shoulder, internally rotate, flex their wrist, and gently tilt their head away in the opposite direction, and they would hold this for 3 to 5 seconds. For operative treatment, this would be utilized after a year of conservative treatment, and if that was not working, so there's different surgical approaches for radial tunnel release at the dorsal and anterior approach, and then there's different surgical techniques of the site to release radial tunnel. So this is 6 to 8 months for recovery, and it's dependent upon the nerve damage. Post-surgery, the client is immediately placed into a splint, and throughout the recovery process, the client is under precautions of no lifting or bending the arm at the elbow to reduce radial tunnel tension. The client can start to progress with guided exercise program from the OT 1 week post-op, where the OT will work on perform soft tissue massages, active range of motion, and then 6 weeks, the client can start to work on strengthening in the forearm and the hand. So there is a lack of research looking at radial tunnel syndrome in its best course, although the literature supports the conservative method being the primary course of action and then surgical if need be. In terms of return to occupational engagement, as long as the patient is showing a reduction in pain and following activity modifications to reduce the movements that produce tension on the radial nerve, they can return into occupations, and typically within 6 weeks. And then these are my references.